Welcome to our roundtable. I'm Jamile Shammo, a hematologist from Northwestern University. And today we're going to be talking about treatment options, specifically focusing on patients with low-risk MDS in first-line setting. Today I am joined by a panel of experts, and I would like them to introduce themselves.
Hello, I am Melhem Solh from the bone marrow transplant at Northside Hospital, Atlanta, Georgia.
Hi, I'm Somedeb Ball from Vanderbilt University Medical Center in Nashville, Tennessee.
Hello, my name is Bart Scott. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington.
Hi, I'm Palmisiano from Rutgers Cancer Institute.
And hello, I'm David Swoboda from Tampa General Cancer Institute.
And our goal today is to talk about how do they decide on what to choose in terms of treatment for patients who have MDS. What is their timing for initiation of therapy, and what is the sequence that they would utilize in this setting? Today, we're going to be discussing treatment options for low-risk MDS in particular, focusing on timing for initiation of therapy and choice of therapy as governed by certain parameters, perhaps transfusion need or other biological markers, etc. Can we talk a little bit about the biologics? Like what drives your treatment choice when you're looking at a certain patient who has MDS? Let's talk a little bit about EPO level and perhaps the presence or absence of ring sideroblast, if anyone wants to comment on this.
Well, I'll start with the commands data. In their subset analysis, the difference between the luspatercept arm and the EPO arm was really driven by the RS positive patient population. In regards to their co-primary endpoint of hemoglobin increase and transfusion independency, it was not statistically significantly different for the RS negative population. And only around 30 to 40% of the people that were enrolled into that trial were RS negative. And I think it's because there was a referral bias. People wanted to get on the luspatercept trial. But the study also excluded people with severe cytopenias. I can't remember exactly what the cutoffs were, but if they had low platelets or low neutrophils, they were not eligible for the commands trial. And I think that enriched for the population that were RS positive. But if you look at just the primary endpoint, the point estimates were actually a little bit better for EPO than for luspatercept in that subset analysis. And my practice had been to favor luspatercept in RS positive patients or who had an SF3B1 mutation. But that has changed because of the long-term data that we talked about that showed, longer duration of transfusion independence with luspatercept and also this potential survival benefit with luspatercept. And I know that it is a matter of debate among our colleagues whether or not luspatercept should be the drug of choice frontline for all patients. But I think the long-term data really supports that, even in the RS negative population. So I used to just give luspatercept frontline for the RS positive patients, but based on the long-term data, my practice has changed. Be curious to see what others think.
Yeah, no, I also agree with that sentiment. I think initially when the data read out, kind of breaking it down, started with more EPO in low ESA patients, but as the data continues to mature and we continue to get more subsets of the data, looking at low EPO patients, comparing luspatercept, ESAs, I am moving to basically using luspatercept in all my patients, and that's what I recommend because of the survival benefit, because of the transfusion independence duration benefit as well with luspatercept. But I don't think that is the broad practice. I think there is debate even within academic institutions, and then I think outside of academic institutions, it's still very heavily shifted in the other direction. And I think as advocates for patients and MDS experts, I think it's kind of our job to educate the community, and so we can continue to improve on the outcomes in MDS.
Yeah, and one thing I forgot, which I know you believe as well, it's totally appropriate to enroll patients into clinical trials. Just because we have a drug, luspatercept, available, we don't want to give up on trying to improve everything.
Yes,
so
absolutely.
It's still appropriate to take patients who are anemic and symptomatic and enroll them into a clinical trial. So everyone out there knows that.
Absolutely. I think that's critical. And there are 2 clinical trials actually that are evaluating certain concepts within the luspatercept luspatercept field, if you will. And I'm sure all of you are aware of those. One is tackling, should we be starting all patients on the highest possible dose? And that on that will be really interesting. And that's kind of interesting since the majority of patients who were on the COMMANDS trial had dose escalation. And then the other one is looking at, I already mentioned that, in patients who have MDS but happen to be transfusion independent, and that's the ELEMENT MDS trial.
And the Cambola study too.
And then the combination of
Luspatercept,
luspatercept
EPO
and EPO.
frontline.
I think the first study you mentioned, the higher dose, I think that kind of is very complementary to the existing data from COMMANDS because our medalist, so to speak, the Maxilla study actually has an abstract this year at ASH, and if you see, when you start with 1.75 milligram per kilogram dose and you compare those responses, even in RS negative population, they look a little better than starting with the usual dose that COMMANDS used. That's in ES and naive cohort. And in ES refractory cohort, if you compare to old medalist data, every metric, every subgroups, the response rates looked a little bit different, although the response criteria or the primary endpoint criteria was a little bit different. In both studies, Maxilla study included, I think if I recall correctly, 1 unit of transfusion got onto the study, which was a little bit different than the COMMANDS or medalist, which were more transfusion heavy. But these things are encouraging to see at least maybe, to counter that RS negative subset, we may consider using a higher dose to see if that helps our patients sooner, if somebody's choosing luspatercept first up based on the survival advantage and other things we talked about.
But was the survival advantage, would there be a patient you guys would not consider luspatercept in the front line?
Yes. The heavily transfusion dependent patients.
Oh, that's right. Yeah.
Because in the COMMANDS trial, they were excluded. So patients who need more than 6 units over an 8-week period of time were not included in that trial, and partly based on the medalist results. So when they did the subset analysis of the medalist trial, they found that there wasn't a benefit of giving luspatercept to those patients who were heavily transfusion dependent, who needed more than 6 units in an 8-week period of time. So we have to remember that, I think we would all intervene before patients get heavily transfusion dependent. But if you happen to see a person who's heavily transfusion dependent, they would have been excluded from COMMANDS. And I think the imetelstat data is pretty compelling for those heavily transfusion dependent patients. Yes, it was given second line for most, but they saw that the benefit of imetelstat was still present even in those patients who were heavily transfusion dependent.
And I think there's kind of 2 other subsets where I would think about it, and that maybe we just don't have the data yet. EPO greater than 500 would be the one, and then patients with high mutational burden. If they have multiple mutations, especially greater than 5 mutations, they're not going to respond to luspatercept or ESAs. And so I think you have to shift and think about something else. What is that something else? I don't think we really know. Is that imetelstat? Do you need to go directly to hypomethylating agents in that situation? But yeah, that's areas that I would move away from luspatercept.
The high EPO patients were excluded from COMMANDS, of course, because it would have been unethical to randomize them to EPO. But do we think that having a high EPO level would affect response to luspatercept? We don't know from the trial data, but from a biological perspective, I've asked myself that question, and I believe the answer is no. So I do think that even in the high EPO levels, there's probably a benefit with luspatercept, but you're right, we don't know from the trial data because they were excluded. But the reason for exclusion was not because of a biological rationale to suspect that luspatercept won't work, rather because it was unethical to randomize them to EPO.
The only data we have actually on people who have EPO above 500, to your point, is in the medalist trial,
study.
but that's second line, that's not first line. But I tend to agree that if somebody has an EPO level in frontline setting above 500, yes, unfortunately we don't have data in the frontline, but in theory, you would think that there is no reason why they would.
Because luspatercept and ESA we know affects different stages of erythropoiesis. One is early, one is late, so it's a little bit different. And also interesting cohort to me is 200 to 500 range. Sometimes we tend to make decisions based on a lower cutoff for EPO rather than higher cutoff. So in my mind, 200 to 500 range is kind of borderline highish EPO level, maybe more sensitive to luspatercept than ESA, and it's hard to prove that, but that's something probably we have practically all seen.
So they looked at that actually in the reanalysis of the COMMANDS trial. Remember when we talked about early versus late? So they looked at patients with hemoglobin below 8, above 8, with transfusion dependency below 2 units, above 4, and even when it comes to EPO level, below 100, above 200, above 100, if you will, or 200. So I think that if you happen to treat people in a conceptually earlier stage, both arms did better. And that applied to erythropoietin also. However, even if you looked at all of them, it appears that luspatercept was slightly better, or even better than erythropoietin, even when you looked at this subgroup analysis. So I wonder what you think about that.
Yeah, no, I think, like you said, EPO level does seem to affect response. The higher the EPO, the less likely they are to respond to luspatercept and ESAs. But luspatercept still seems to hold its response despite the increasing EPO level. I think in the above 200 population, it was still about 50%, where it was like 15% with ESAs. And even 15%, I was sort of impressed in above 200, because other studies have showed almost 0% response to ESAs. So no, it's encouraging that, obviously it still makes us think, yes, use it earlier, use it when the EPO level is lower, but that's not going to be the case for all the patients that show up at our door. So we still know that the patient can respond. We should try the drug. It's just, setting the expectation that it might not work as well.
But back to Scott's comment, even in a group of patients where you'd expect EPO to do well, the design of the study to be ethically fair, luspatercept still did better. So for patients with a high EPO, where ESAs aren't going to do that good of a job, I mean, your option normally would have been to avoid them and go somewhere else. So
Exactly.
True, we don't have data in the front line, but we do have the second line data that showed there's still responses with high EPO levels.
Well, I'd like to thank the panel for a provocative discussion on the management of low-risk MDS. Thank you all for participating.
Thank you.
And thank you for joining us.
Thank you.
Thank you.
Thank you.